So it's my pleasure at this point to bring us to the part of the program where we have, really it's the highlight of every ISGEO meeting, is the Elizabeth Cass Lecture. I'll say a few words about Elizabeth Cass, who was a remarkable character. So I have a few things to say about her, and then I get to introduce our lecturer this year, who will deliver the Elizabeth Cass Lecture, Professor G.V.S. Murthy. First of all, this is the only photograph any of us have of Dr. Elizabeth Cass. This was taken up in the Northwest provinces of Canada. She had 2 huskies. One was very docile, slept at the base of her bed. The other one would always be guarding the door. And if you would visit her at her home, you'd be extraordinarily careful not to do anything too suddenly around the protective dog. He was extremely, at least looked ferocious. I'd mentioned yesterday that she was born in the UK and was a co-resident along with Duke Elder and Ida Mann. She's really part of that whole generation. I mean, those of us who are old enough to know all this, know she was part of a very influential and important generation of a development of ophthalmology in Britain that then, of course, became the standard for the world. She had her own strong interest in communities around the world, and that was part of what attracted her to move to one of the most isolated parts of the Arctic portion of Canada, where she lived her last 30 years. She was a remarkable networker. She knew all the key ophthalmologists from around the world and was able to organize the idea of a Congress that didn't focus on clinical ophthalmology, didn't focus on surgical skills. It focused on community eye health and what can we learn by knowing more about the community as we're working to prevent blindness and restore sight. So she was really a dynamo. People who wrote about her mentioned that she single-handedly organized the first 2 ISGEO meetings. Back then, it was called ISGO. The E got added in more recent decades. But the first meeting was literally all the way up in Yellowknife, Northwest Province, Canada. The second one was in Jerusalem, sponsored along with Dr. Michelson, who was a very dear friend of hers. She passed away in 1980, and then by 1982, the first Elizabeth Cass lecture was given. Then there was a long hiatus, and then we've had 8 more. We get to have the 10th Elizabeth Cass lecture today. The first lecturer was Dr. Viggo Clemenson. I'm not sure how many people in the room would have known Dr. Clemenson, but he was extraordinarily active with the precedent organization to the International Council of Ophthalmology, and really was big about bringing together the International Council, the World Blind Union, and working together to start IAPB, International Agency for the Prevention of Blindness. This is Dr. Viggo Clemenson speaking in California at that Congress. When we talk about Cass lecturers, we're really talking about the who's who in eye health research. I mean, look at these people. From 2004, Dr. Marilyn Miller in Dubai, Serge Reznikov, Professor Jai Prakash, Gordon Johnson, Alan Foster, Hans Limburg, Hannah Fall, and 5 years ago, Claire Gilbert was able to give the Cass lecture at our most recent ISGEO meeting, which was held in Hyderabad. And as I said, Professor Murthy's team was very instrumental in hosting that meeting. As I introduce Dr. GVS Murthy, I won't go into all the details. We'll have a very nice page about his background in the materials for this meeting, and also many of you know him already from your extensive work with him in one of any of a dozen countries doing population-based studies. And he has really, for me, been inspiration in just showing what can be done. I mean, I remember in the 1990s, we were together with release of important data in India. And it was just so important to know that the government would be hearing real data. And then in the early 2000s, tuning in with you regarding the coordination of all of those RABs that you were developing all around India, between 35 and 45 of them over a period of years, which again provided a cornucopia of information that India was able to use for decades to come. And finally, I wanted to be sure to recognize Professor Murthy at the last ISGEO meeting with our Jyoti Shah, who's really making things happen, Parikshit Gogate, and Claire Gilbert. And to me, the picture of the four of them really just exemplifies the organization and how longtime friendships, longtime collegial relationships, and learning from one another has been such an important component of the organization. Also, of course, Professor Murthy has had a lot of roles with IAPB over the years and at the major IAPB meetings. In this instance, taking part in a 2030 live panel. So I just am very appreciative that you've made this trip. You've come up to Kathmandu. The air is a little thinner. And we get to enjoy your lecture, Professor Murthy. Thank you very much. Would you please come to the dais?
Thank you, Suzanne. Thank you so much. Oh, so that was really moving, because for the last ending 2018, and I was looking at those Elizabeth Cass lectures, 6 of them, I was searching, where is the cat to be built? And since catch up with you, and finally Suzanne's told me that karma means the sin catches up with you. So this time you deliver the Cass lecture. So you never get away from this. It's really an honor to be here and share some of my thoughts, some of the experiences, and the times that we have all spent together in different parts of the world. I would like to just look at some of the problems that we create for ourselves by not having a guide next to you. You could go into a dense forest and you don't have a guide, then you lose your way. The same is the thing with not having a driving license, looking at a video on FACO, and then going to operate on a number of people, not one, but a number of people, till they turn back, like it happened in one of the hospitals in India just about 2 weeks ago, just about 20 days ago. There was this guy who was a cardiac surgeon, a pediatric cardiac surgeon, operated on a number of children over 3 months. 7 children died, and then they suddenly found out he was just a con man. He didn't have a degree. He never was a pediatric cardiologist, but went on to do angioplasties, angiographies, and everything, and kill people. We don't want you to do that. We don't want you to get the police get you, or be in an ambulance where you're carried away, or the worst, going to the mortuary. The fourth big danger today, of course, is the legal profession. I hope none of you sitting here are legal professions. But that, after the fiasco with the lack of screening for retinopathy or prematurity, what you saw was that the legal system can also haul you up. So it's not just three, but four ways in which you could get hauled up if you do not have the evidence to actually steer the car safely. I would not go any further than what Suzanne has just mentioned, but just to add that today, if we are in this room talking about research happening in public health eye care and not going on into a clinical discipline, is because of her. It's because of her conviction that all of us are gathered here, and the movement is gaining steam with about 120 people registered and attending this conference. So that's a great tribute to her. There was another photograph, Suzanne, where she has an air rifle sitting with a hunted cat, where she's with 7 people at the Yellowknife Congress. Right. So, in terms of where all I've been, I've not been to as many as Suzanne has, obviously, but I've worked in a number of places, and this is basically in terms of generating the evidence for action. But I'm not going to go into all those countries. I would like to use one of them as an exemplar and look at how evidence can actually make a difference. And therefore, I'll use the India situation and how evidence played a major role in the Indian context. Let me just take you to this. It's an evolution, so obviously it is going to be starting from my year of birth, 1956, when we had the results of the first trachoma survey in India. I was born the same year. That's when evidence started becoming important to actually plan actions. That led to the trachoma control program, which was the first systematic national effort. In fact, most parts of the world, the trachoma control program became the first systematic way of dealing with blindness. And then this moved on, and then we moved on to the next stage, which was the trachoma control program per se, and then we had the National Vitamin A Prophylaxis Program. Now, the National Vitamin A Prophylaxis Program was not run as part of the blindness program, but more in terms of the nutrition program, where eye care had a collateral benefit, which is good. If somebody else is doing the hard work and you're getting the benefit, no regrets. Let somebody else spend the money and you take the benefit. The first time that national level comprehensive blindness data started getting collected was the ICMR, the Indian Council of Medical Research, when it conducted an 11-center study over the period 1971 to 74. And that is a very poignant moment in the history or the evolution of eye care control activities in India, because that report was used by greats like Dr. V and Dr. L.P. Agarwal to convince the then Prime Minister of India, who initially said, I'll just give you 5 minutes to just talk about what you want to come and tell me. And when they started telling her about the findings, that half an hour became 2 hours, became 4 hours, and ultimately led to the National Program for Control of Blindness in India. So advocacy can make a difference was first shown by these doyens of ophthalmology in India. And that actually led to a large interest in collecting evidence regularly. 1976, we had the program being started. And then over the period 1986 to 89 was when the first national level, what was truly representative of all populations, all regions of the country. It was a national survey. Unlike all the others, which are either stringing regional surveys or stringing different parts of the country and generating estimates. That was the first and only national sample survey which was done in India. And that led to the alarming figure of increasing blindness and increasing prevalence of cataract related blindness, which then brought in the attention of the World Bank, which came in with a very handsome package to try and make a difference. So, the World Bank project is a watershed moment in Indian eye care because that brought quality into perspective, because prior to that it was just quantity. And that, I think, is why we need to look at that as the watershed moment. Then, of course, when Hans was here, the first rapid assessment of cataract surgical services from 1997, where, of course, Tulsi played a major role in the conceptualization of that. That was where the RABs that we've been hearing about today actually were conceptualized. And then it was, of course, improved upon over time. Then we had the 15 district survey in the World Bank supported project over the period 1999 2001, and the series of RABs that was strung together in the Northeast, in the World Bank states, in the non-World Bank states, and then in 2007 having a 15 district RABs which were done in 15 districts, and the evidence was collated together. And more recently, we've had Praveen Vashist and his team. I stand corrected, it was 31. I thought it was 30 districts, where they've tried to show what the difference in the country is. So I would like to divide that into two phases. The first phase, where the program was a low priority program, limited budget of about $600,000 a year, little performance in terms of cataract surgery, though it was the commonest curable cause of blindness in India, mainly as a public funded program, and there was an increasing prevalence of blindness, basically cataract related blindness. And then the second part, which is after the World Bank stepped in, it became suddenly a high priority program. That $600,000 suddenly went to 1260 million per year expenditure in India in terms of the national program. Massive increase. Increased performance, tripling of the performance from before the World Bank to about 3.7 million surgeries by 2004. Of course, now it's much higher. A decentralized implementation program was piloted, was found to be successful, but instead of waiting for a more wider pilot, it was immediately pitchforked into a national program, which is why it doesn't exist in the form that it was conceptualized in. There has been a gradual decrease in the prevalence of blindness. So, how has evidence transformed the way the program works in India? So, that's why it's evidence to action. Advocacy, I've mentioned how the two stalwarts, and of course, with Sir John Wilson also being there, but all of them together making a difference. Then creating that ecosystem for collaborative efforts, which came around the time of the World Bank project, where these collaborative links started increasing, saw increased funding, upgradation of the infrastructure, skills, technology infusion, which is now, the last session was all about artificial intelligence. So there's more and more technology infusion. The importance of quality, all of it has actually come because of the evidence. Action without evidence is dangerous. Action with evidence is a progressive development in human evolution. There was certain course correction. I mentioned the District Blindness Control Society. It could have been done differently to make a better interest. And instead of the money that was earmarked for the blindness control program, which was getting used for other programs like immunization, it was decided to give things as a commodity assistance. Intraocular lenses, sutures, equipment was procured centrally, which got huge discounts from the manufacturers. And because it was not a cash transfer, it was easier to actually equip the entire country. Financial allocation increased, and a specific augmented cell was created in the ministry. So this, like I said, is a watershed. $117 million that time. In today's world, it would be equivalent to about $500 million. Looking at the inflationary pressures, that's what that value was. And that bolus made a difference which we did not imagine. I'm sure Tulsi also wouldn't have imagined that it could have led to the sort of difference in terms of quality, in terms of change of attitudes, in terms of change of practices. What happened immediately was that most districts, when we did the RAB in 2007, showed a decrease in the prevalence of blindness above the age of 50. Only 3 districts in the country, they had an increase, but that again was a marginal increase. Some states like Bihar, there was a sudden increase in the life expectancy, and that could have explained the change in the prevalence of blindness. But overall, there was a difference. If I look at from 1998 to 2007, the average decrease across the country amongst the 50 plus was from about 12.8% blindness to coming down to about 8%, which was significant. Now you're talking about 1.5, 1.6, but remember when it was in double digits. Prakasham in Andhra Pradesh, we were lucky that we could collect information at 4 different time points. And what we see is that from about 7.9, that's about 8% blindness prevalence above the age of 50 years, by 2014, you've been able to reduce it 400%. And that is what is the figure that we must keep, 400%. From about 8% to coming down to 2% is a 400% decrease. That was fabulous. And this is happening today. Another collateral benefit was this District Blindness Control Society. So if you look at prior to the District Blindness Control Society, ophthalmologists spent about 40% of their time, 20% to the outpatient, 20% in the operating room, about 40%. And look at the change that this approach brought, where the ophthalmologists did not need to worry about the admin that they need to look at. Came up to 75% of their time was then used either for outpatient services or for the OT. Now, that is the sort of difference which could have been embedded within the health system even till date, but unfortunately, certain things changed that. But this was a collateral benefit of the national efforts. So now let's look at extrapolating this to a national level, which to all ages, which is what people do. Only the 1986-89 survey was an all-age survey till now. So that is the most accurate, perhaps, estimate of what the national prevalence may be. All the others go with the assumption that 90% of blindness is above the age of 50 years, and the rest we are extrapolating. So we are actually doing assumptions within assumptions, trying to arrive at that figure. But look at the difference. It's just about a 66% decrease in overall prevalence if we look at these figures from the 1971 survey to the last survey, the 31 district survey. So it's still a lot of work to be done. Let's be mindful of that. Yes, a lot of big gains are there, still a lot of work to be done. Looking at the causes of blindness, I've put all these surveys together. You find that there is a difference, but it's not a very significant difference. And that could be because of the methodologies of the examination protocol itself. A detailed survey where a complete examination is done would perhaps give you the best estimate, which was in 1999-2001, 62% cataract blindness. The latest RAB is about 64% or something like that. So it's 66%, not much of a difference. The place where the difference has come in is on infections. Smallpox, which many of you have not seen, many of us have seen,
And when I was in medical school was when smallpox was eradicated. That, along with vitamin A deficiency, were the biggest blinding conditions. And they have all gone down. They are historical now. And that actually made a big difference. But in all the others, whether you look at glaucoma, the posterior segment, because of the methodologies adopted, it's almost very similar. And if you look at this confidence intervals, maybe there's not much of a problem. But when you look at these figures also, you look at across uh, the entire country in terms of cataract blindness, you find there's a wide variation across the districts, which means that for your plan, you need to look at doing something locally rather than depend on a national average. Otherwise, you're either overestimating or underestimating the burden. IOL surgery, look at the change that the World Bank project brought in. From something as low as 3% intraocular lenses in 1994, going up to 683% in 2004. Just imagine in 7 years, people change their practice. So it can happen. Don't think it cannot happen. And today, from Dr. Praveen's survey, you're looking at 94% intraocular lens implants. So one can change practices if the evidence for that action is available. And even there's a wide variation. Rajasthan, it was only 5%. But look at the more developed states where you had more of the private sector. Gujarat, the private sector is active. Kerala, Tamil Nadu, AP. These are states where the private sector is a major player. And there, the intraocular lens conversion took place much faster compared to states like Rajasthan, Bihar, or UP, where it was mostly public funded. Look at the best outcomes, and we've been talking about this after cataract surgery. I'm looking at BCVA because that was what was mentioned in the morning. Look at the bad in outcomes. 8.5% in 2018, 10.2% in 2007, 8% in 2001. Hardly any difference. So we are still left with a lot of work to be done. How we reach that and reduce that to less than 5%, because you're looking at the best corrected vision here, is a challenge. And we should not forget that there's still a lot of work to be done. Cataract surgical coverage, which Dr. Praveen had presented just now in the last session, again has increased dramatically. From 65%, there's a 150% increase if you look at percentage terms. And if you add effective, then it starts dipping. So there is a lot of work to be done. And then we have the transitions, and therefore you have more recent work which has happened. I'm not going to technology because that was there in the last session. But looking at the health system in India, 80%, 74% of all the medical workforce, that is the trained medical workforce, is in urban areas. When you look at ophthalmologists, this becomes 82% compared to the rural and urban. And we have this four-tiered system, including the community level workforce. And therefore, we would expect that if we had to make a difference and make services more equitable, then that rural areas where the government is the only provider right now, and where the widowed women, the elderly who are dependent, all of them reside. And therefore, that challenge is something which still persists. I'll just look at the ROP and DR as a new initiative which happened. These have led to an increase in the funding available for both the activities. A lot of the international funders have come in to support the activities in India. And in addition, a lot of governmental interest has been fueled because of an integrated approach which was tried out. We thought we could work in 5 states in relation to ROP and 11 states with diabetic retinopathy. 2 governments did not give permission, so we left one in the ROP initiative and one in the DR initiative. But both these very clearly demonstrated that an integration with the government health system, as well as bringing in expertise from outside the ophthalmic work system, is very, very critical. If you're looking at diabetic retinopathy, it's the physician who's critical to managing diabetes. You should agree that you are a peripheral player. You are not the central player. The diabetic physician is a central player. Even for ROP, it is the neonatologists and obstetricians who manage the reduction of risk of ROP. And therefore, we have to agree that we are willing to take a secondary role, giving the primary role to them. And that is the paradigm shift that we need to look at going forward, which means a lot of task shifting. Whether it is ROP, and there it is nursing personnel who are taking the photographs in a district in Telangana in South India and getting very good images which could be read, which had ungradable images only in less than 10%. 91% could be read with a camera being used by a general nurse in a newborn care unit. And that's task shifting. Same thing with the diabetic retinopathy program. And a lot of the teams sitting here have been part of that. So task shifting can be done, needs to be done with the newer challenges that we are facing. Especially look at this WHO indicator. How can you reach 80% to be screened and 80% to be treated unless you cast the net wide and get everybody in? Only the ophthalmologist or the optometrist, I'm adding the optometrist too, together they cannot solve this problem. And therefore, AI, which people are talking about, increasing the reach, getting more and more people into the matrix, is perhaps one way that we have to look at going into the future. Challenges are there. Reducing inequities, which is what I've just mentioned, gender inequities, geographic area inequities. These are things we need to look at. Reduced funding now post-COVID is another problem. Lack of a dedicated research budget, again a headache. And the use of advocacy for evidence in eye care in planning services still is a message that needs to be taken across. And quality assurance and monitoring mechanisms need to be strengthened further. There's a need for long-term intervention. A condition like ROP is not a one-time intervention. You need to follow up that child till the age of 18 at least. And therefore, you must have a modality in place which can make that happen. And most of it will be outside the ophthalmic hospital. The increasing cost of care is something you have to keep in mind, and monitoring the out-of-pocket expenses. More research needed on the economics, the cost effectiveness, the cost utility of different interventions in eye care, which still is just at the fringes, and identifying appropriate indicators, which have already been talked about. We need to look at how we elevate, integrate, and activate these for 2030. So you have the problems. On the one hand, increasing life expectancies and the inequities which have not been addressed are becoming more and more of a problem. On the other hand, the interventions need to catch pace with them, and which is at the moment not happening. We're looking at ECSC, not CSR, and effective refractive error coverage. Excellent indicators, but how do we collect that? And how do we actually use that to improve quality, to drive quality, is something which is very, very critical. Evidence-based practice, increasing vision needs means more demand on eye care services. Earlier interventions demanded by people. The demographic penalty in most of the low and middle income countries, Nepal, India, we all pay that demographic penalty because more and more people are suddenly growing older, and we cannot keep pace with that. And the epidemiological transition in diseases. Finally, Perseverance and quality assurance are the two driving forces with the evidence to make change happen. Now, that was in Bharatpur, where we walked 12 kilometers to one hamlet which has just 200 people, but we didn't want to miss anybody in seeing that the response rate was above 90%. Walked up and down, that is 22 kilometers that day, but it was a wonderful experience that we could reach. We talk about last mile connectivity, last mile reach for evidence collection is also equally important. And that was in Bangladesh with my friend Mohit for a disability survey. And then, of course, this is in Nigeria, where inter-observer agreements which need the seriousness were being conducted. And Claire and me were in Sri Lanka for the blindness survey. So quality assurance and regular monitoring with perseverance to reach the last hamlet that you require to reach are important to make a difference. We talk about confluence of stars, and this is in many regions in India, Nepal for sure. We talk about the confluence of stars making a difference to where action happens. And as far as the World Bank project coming into India or the change happening, it once again was a confluence of stars on the firmament. That is Mrs. Shailaja Chandra, who was the additional secretary in the Ministry of Health and Family Welfare, who was responsible for the blindness control program. I couldn't get Dr. Amarjeet Singh's photograph. He was the joint secretary in the ministry. Dr. Damodar Bachani, who was a program officer, along with Dr. Rachel Jose, who was the lead of the ophthalmology program. Hans Limburg, Tulsi, who's sitting here. I'm so happy to see him here. Rajkumar. And luckily for me, I could say that I was fortunate enough to join this Confluence of Stars to make a difference to the journey of blindness control in India. It happened. It will continue to happen if you use evidence properly. Thank you very much for the honor. Thank you, sir.
Step right here. Thank you.
From the ISGEO team, the whole ISGEO team, to say thank you very much.
Thank you so much.
That's a lot to think about. It's sort of exhausting, actually, GV, that you're reminding us of all that's happened, but all that needs to happen. So thank you very much. Beautiful lecture.